I would like to, at the outset, I would like to thank Scientific Committee of ISOT for giving me opportunity to speak. So I'm going to speak about robotic kidney transplantation, what is the status, and we have done a lot of modification to make it simple and cost effective also. So we all have seen it, the big incision, and we have seen sometimes, especially in obese and diabetic patient, they get infection, lymphocyte, and uh, and it's quite painful incision. So, but once when you do the minimally invasive procedure like robotic, then you can avoid all that. You can small scar, cosmetically better, less pain, less analgesia. Surgical site infection is very less. No lymphocyte, early recovery. So what is done? It has made transplant easy. This was the first transplant done basically in obese patient 2007 in Chicago in a 29-year-old. Even in that patient at that time, there was a blood loss was only 50 ml, and patient was discharged within 5 days. And then the major breakthrough came in 2012 when Dr. Lawat and Dr. Mani Menon published their new technique, and then there was a lot of advancement has happened, and many publications since then has appeared to show it that this is not now in uh, imagination are the only to be done by few people. It has got the widespread application, and it has shown that it decreases the blood loss, it decreases the infection rate. And this meta-analysis says, which has come in 2023, that robotic transplant is associated with low incidence of delayed graft function, post-operative surgical complications, similar mid-term functional outcome, patient and graft survival. So it is now no way inferior to the open transplant, and now it looks like in many ways it is superior to open transplant. And you can see that is the open surgery, and this is the robotic incision. And after few months you hardly see where was the incision. And this is my donor and recipient. When they came for follow up, recipient complained why my incision is bigger than my husband incision. And this is the one patient who was denied transplant in Singapore and Bangkok. So when he moved in, came to my room, his first thing was, the will you do my transplant or ask me to lose weight? If you ask me to lose weight, I'll go back. So, and then we get many obese patient from various countries, and the advantage in obese patient is that infection rate is less, blood loss is less, it is easier operation to do, and even CMV infection is less. Initially everybody complained it takes longer time to do it, but when you start doing it you can finish it. Now we finish the whole operation by the time kidney is dropped, and we revascularize is around 40 minutes. So you can do multiple vessels, you can do three vessels. I have less time. So, and right side is very easy, because when you do open operation, right vein is short and you go there and do it. But when you do it, put the right kidney there and you can easily anastomose. So now say that if you have right kidney, do it robotically. It is a good indication. You can place kidney right side, you can place kidney left side, any side you can do it. There is no problem. You can put kidney upside down. You can do the operation for if you are doing allele conduit, or for some reason you want to do upside down, you can do that. And this is another good condition. I have seen indication for somehow it was missed when they explored. They saw that right side vein is completely gone, and they can't find it. We tried to put the needle, there was no blood flow. So in open operation you might have to go higher up or go to the opposite side, but here it was so simple. We moved to the left side and finished the operation. So that was another advantage. Pediatric patients are quite happy. You can do it in pediatric patient, and you can see most of our Indian ladies wear saris, and where this phalangeal incision is not seen, so they like it very much. And even if there is atherosclerosis, you can fix the intima and then go ahead and do the operation. You can do orthotopic transplantation. It has been done in Europe, and I am looking for a patient to do so. And nowadays it is possible to take the kidney out. If you have a donor and recipient, both are female, you take the kidney out from the vagina and drop the kidney through the vagina and do the transplant without any incision. You do the cadaveric transplant. We had obese donor, and so we by the time our robot was ready, so we did the with the robotically. So, and we have many modification. We always do artery speculation. I know many people don't do it, because this way we hardly see any renal artery stenosis in our program. We speculate and then you tag it with the sutures, artery and vein, so that you know this is the upper one. It also helps in moving the vessels up and down. When you finish it, you must do a leak test to make sure there is nothing is leaking from the vein. Otherwise, doing anastomosis when it is bleeding is little difficult. But you can do that. It's not it can. And we also spatulate the ureter over the infant feeding tube, so we know which side it is there. Then there is a jacket preparation. This jacket, put the ice all around. It helps you at least for 10-15 minutes. Ice is there, then it just melts away. But that's cut down your rewarm ischemia time and helps you in uh, avoiding this warm ischemia time. You can do with the this way, or you can put in the glove, and you can do it. Putting the glove, it is easier to slip, but what happens? Just ice goes up and down only, upper pole and lower pole. Then you drop the kidney. If you have put the umbilicus, then you can drop through the umbilicus. If you have pharyngeal incision, you can drop through the pharyngeal incision. If you have put the Alexis port, you can do it in both the way, whatever way you like. We have published our this technique of knotted sutures, so that in vein you just have to do one tying, and in artery you just have to do two tyings. It saves at least 3 to 4 minutes. So in early stage, it is important. We used to do this arterotomy using the pot scissors. It was easier, but now we are thinking of cutting down the cost. So we stopped doing the pot scissor, and in few video you will see that we are using the normal scissor. So that way we save the use of one instrument. So we now use only 5 instruments. You can do multiple vessel reconstruct into one and can do it. But if they are too far apart, you can do two anastomosis. This is the multiple vessels doing the anastomosis. And if you have 3 vessels, we published this paper, got the best paper award also. You take out the internal iliac artery of the recipient, and then you got a graft, and that graft goes, and you can anastomose with the 3 vessels or 2 vessel combination or whatever you do. So now you have a single vessel to do the anastomosis, and that way you can save the time. And so that's how you can retrieve the graft. So time is less. I will modification of peritoneal flap. You just make peritoneal flap enough so that kidney sits. So you once kidney you have retrieved, you have idea how big is the kidney, or you measure it in CT scan. Accordingly you make a graft. If you make too much, then kidney slips into the graft and gives some tension to the anastomosis. But if it is more or less good size, then it stays there. Erythroneocystostomy we do exactly as the open operation and use 50 or 40 Vicryl. So there is no extra cost for doing it. Same stented anastomosis. You can put the kidney left side, right kidney left side, right kidney left, right side, whatever way you want. All operation is easy. We have done all combinations. This is the Dr. Teneve has suggested. So I'll just, since he is here, just give me 2 minutes to show it, that why you are lifting the shifting the kidney from medial side to lateral side. Why don't you keep the kidney there and do this? So we did this. We kept the kidney in the iliac fossa and then did the anastomosis. The only thing is that you have to do little more dissection of the artery and vein. It is more difficult than our routine procedure where the kidney is lying in medial side and then you flip the kidney to lateral side, but it is all possible. We did it there when I was in Japan with him, and we did 3 cases here, but it is more little more difficult, but it is possible. So you don't have to flip the kidney, and his kidney can stay there. So that kind of modification is also possible. So basically why I'm saying that, now with the next slide I will show you that everything is now mimicking the open transplantation. You can see it here. It is the normal Caesar we are using for arterotomy and venotomy. So this is that everybody says that transplant is extraperitoneal approach. You are doing transperitoneal. So our extraperitoneal approach is also accepted and going to be published next month. We have reviewed everything, so this will be published, and you can create extraperitoneal space, and then you can drop the kidney from phenyl incision, and you can do the operation. It takes longer time to prepare the uh, it take extra time to do the operation because you have to prepare extraperitoneal space, which you don't have to do in intraperitoneal one. And there is another thing is that you can do the operation in horizontal position, but once you drop the kidney and flip the kidney to medial side, at that stage the bowels are there, so kidney is not sitting nicely. But if you do the little bit 15-degree Trendelenburg, then bowel moves away and kidney sits nicely. So we realize it after 3 4 cases. Now we are doing this operation routinely and trying to do it in a obese patient, and will show how difficult it is. It is difficult in obese patient, but slowly we'll learn to do it. So this is the extrapersonal space. So what I can say it, that robotic assisted kidney transplant is feasible in almost all conditions: right side, left side, orthotopic position, first transplant, second transplant, live, cadaveric, multiple vessel, scarless surgery, morbid obese, patient on antiplatelet, anticoagulant, dual kidney transplant. So it is possible in all situation, in all patient, but these are the four category of patient where it is very good. Young female, phenyl incision is hidden. Obese patient is a real indication. Pediatric patient, but the patient has to be around 10 years of age. You can't do it in four. If the weight is only 10 kg and baby is very small, because you need to have a space to work there. And right side kidney donation, it is not written there, but right side is also very important. You can do it easily, and those who can afford and can avoid morbidity should opt for robotic assisted kidney transplantation. You can't stop the progress will run over you, said by the great surgeon Thomas Stargell. Thank you.